We at Bacterial are honored to be working with Dr. Stephen M. Brecher. He's the Director of Microbiology Laboratories for the Boston VA Healthcare System. He holds academic appointments with Boston University School of Medicine and the University of Massachusetts at Dartmouth. Dr. Brecher has been honored as an American Society of Microbiology Foundation speaker.
One of the problems in the laboratory today is the lack of young students graduating in medical technology. Another part of that problem is it takes me and my staff 2 to 3 years to get a well-trained microbiologist. Some of the laboratories, like chemistry, hematology, have become highly automated and very accurate, very rapid, unbelievable technology. But microbiology is getting better. We have PCR, we have rapid technologies, but we still do a lot of things the old ways. You look at culture plates, you hold them up to the light. You look at different colonies, you gram stain them, you touch them, do they roll on the plate? You look for hemolysis. You have to learn how to do susceptibility testing. Yes, we have machines that give answers, but any good microbiologist knows that the answers are only right 80 or 90% of the time. It takes years to make somebody very knowledgeable. So one of our great problems today is the lack of young, educated medical technologists coming and or staying in this field. For rapidly growing bacteria, we're really talking about 24 hours. So we can have a colony in 24 hours. Then it took another 24 hours to do a susceptibility test and identification. If there were mixed organisms, we might lose another 24 hours doing isolation. If it was a slow-growing organism, it may take another 24 hours to get ID and susceptibility. So at our best, we could do this in 48 hours. In bad situations, it could take 96 hours. And these are still the rapidly growing organisms. By going to rapid bacterial diagnostics and using some of the new technologies, the biggest change is that we can get results in hours. And what that really means is I can communicate those results, or members of my staff, to the medical staff in the hospital. And then we can do therapeutic interventions, we can do better infection control, we can get answers so much sooner that we can actually affect the outcome of patient care. The ultimate goal is to get patients out of the hospital sooner. Now, the way we do that is if we get the right answer, put them on the right antibiotic, we can then send them home. And that's, even though this is an issue that comes up, a lot of these new technologies are more expensive. And people will argue, how can you afford to do a test that costs $40 when the other test costs $3? Well, and my argument is the biggest cost is length of stay. A day in a hospital is a minimum of a few $1,000s. So if I can spend $100 and get someone out of a hospital 3 days earlier, I've actually done a favor for the patient and a favor for the healthcare system. The microbiology world is changing much more slowly relative to other of the medical technology fields, really because it takes organisms time to grow. So if you have, you're feeling funny and maybe you're diabetic, in a matter of seconds, we can draw your blood and tell you that your glucose is 40, bad, 400, bad, or 90, good. But if you have certain infections, let's say we think you have bacteria in the blood, it still takes at least 24 hours to get a preliminary diagnosis. I have to take up to 40 mLs of blood, 20 mLs in 2 separate phlebotomy procedures, put 10 mLs in each of 2 bottles, repeat that, stick the patient again, and then put those bottles in a machine, which is an incubator. And the soonest the blood culture is positive is maybe 8 hours. But on average, it's 24 to 48 hours. So if I think you're septic, you've come into the ER, I've drawn blood cultures, it's 24 hours before I have any result. And then I have growth in a bottle. I have to gram stain that and say, well, it looks like this or it looks like that. It's gram-positive rods, cocci, gram-negative rods, cocci. But then I have to plate it out. That takes another 24 hours. I can set up a direct susceptibility, but that's by non-standard technology. If we had the ability to determine the presence or absence of bacteria in urine quickly, that will make a big difference. And what I mean by that is if we can say there are no or so few bacteria in this urine in a fairly short period of time, it means we don't have to use antibiotics when we don't really need them. Because cultures take a long time and because urinalysis are not very accurate, if there are symptoms of a urinary tract infection, often the physician or the nurse practitioner will say, well, looks like you have a UTI. Let's give you 3 days of this antibiotic and let me know how you're doing. What if in an hour or two we can say, that's negative. You really don't have a positive urine culture, or you won't have a positive urine culture. We can avoid giving antibiotics to a large number of patients. If, on the other hand, we can tell in a few hours that there are a significant number of bacteria in that urine, then we can try to direct our therapy. We still don't know what those organisms are. We still wouldn't be able to absolutely tailor the antibiotic until we knew the name of the organism and, in some cases, its actual susceptibility. If we had the ability to find or look for certain genes at that point, that might help. Rapid bacterial diagnosis can also greatly aid in the development of new antibiotics. One of the issues with the development of new antibiotics is cost. It takes about 10 years and costs somewhere between $1 billion and $1.7 billion to get a new drug to market. If you could more rapidly diagnose the infection and the organism causing that infection, you can determine if that patient is the appropriate patient for the trial. In many trials, you need 100 to 200 to 300 patients, but we have to test 1,000 or 2,000 patients in order to get those 100 or 200 that fit the trial. Using rapid bacterial diagnoses, if we can get that answer in a day or two sooner, then we can greatly reduce the cost. There are very few organisms per milliliter of blood. Urine is a whole nother opportunity. Now, without getting into all of the complicated definitions, I want to just start with acute cystitis. In acute cystitis, the definition is you have greater than 10 to the fifth, 100,000 organisms per milliliter of urine. Now, when I described blood, I said you need to take 40 mLs of blood, put 10 mLs in each of, sets of bottles. When we culture urine, we use 0.001, 1,000th milliliter of urine on a culture plate. We may put 0.001 on a few different plates. We grow it up overnight, and if you get 100 colonies, because you're really doing a 1 in 1,000 dilution, you can look at a plate the next day, you see 100 colonies, you don't have to count each one, you can just guesstimate it and say that patient has greater than 100,000 of a particular organism, they have a urinary tract infection. This is a big part of what we do. Depending on your laboratory, 40 or 50% of the cultures are urine. And the majority of them are negative. They're no growth. And if we had a way to get rid of no-growth urines in an hour or 2 or 3, that would really tie up some time so we don't have to look at these plates. Because we look at these plates at 24 hours, and also because of yeast and other more slowly growing organisms, we look at them at 48 hours. So to diagnose a urinary tract infection still takes a minimum of 24 hours and is fairly labor intensive. And it's a big part of our workload in the laboratory. One of the big changes in the last few years is our ability to rapidly diagnose and accurately diagnose infections and the carrier state in certain cases. An example that I'd like to use, which was a very important problem that happened at the NIH in 2011 at their cancer hospital, was they had an outbreak of a carbapenemase producing Enterobacteriaceae. Some people use CRE, some people use the term KPC. And these are some of the sickest patients in the United States on cancer protocols for treatment. They're getting infected with an organism that essentially can't be treated with antibiotics. One of the great challenges was ending this infection and finding the organism not only in patients who were sick, but in patients who became carriers and in the environment. So the ability to not only rapidly diagnose this was very important, also the ability to do the genetics on the strains once they were isolated to show that they were related was also very important. We have also worked with McA, Mercer, and there are many arguments that one can put forward as to why the rate of Mercer is down about 10% in clinical infections in the last 3 or 4 years. One of the arguments is by doing nasal anterior nares cultures and looking for people who carry Mercer, which often they carry in their anterior nares. Or it may be because of this increased awareness and what's going on in the lab that's translated into better infection control techniques. In particular, more people washing their hands, more people using alcohol gels. With respect to a disease known as Clostridium difficile colitis or infection, we have gone from a test that was 50 or 60% accurate in diagnosing patients who have Clostridium difficile, toxin-producing strains, to a PCR that can detect accurately 95 to 98% of patients in about 45 minutes or less. So having that ability has made infection control work better, and that all relates to what's going on in the lab and the communication of those results to infection control and other players in the hospital.